our discussants?
So it's going to be.
I volunteered if that's not a problem.
Who is I?
Eamonn.
Eamonn. Well,
Yeah,
I'm aiming at you.
Yeah.
So tell us about yourself.
I am a third-year dermatology resident in St. Louis. I went to medical school with Mohit, and I'm doing a complex med derm fellowship in New York next year. So I have a special interest in maintaining my internal medicine knowledge.
Oh, we will maintain it for you tonight.
All right, good.
Thank you. If anybody doesn't know Dhruv, just too bad.
And in multiple languages, no less.
Yeah.
As Thiago knows.
And once again, we have the rising chief resident at WashU, and I don't mean to be harsh. I've obviously been listening to the Curious Clinicians, and Hannah has me thinking in puns. So, okay, Mohit.
Right. So
your buddy Alonzo apologizes, but his wife had plans for him.
Yeah, I heard. Okay, so today's story is about a 26-year-old male coming in.
Is it a male human?
Male human, yeah.
Okay.
Coming into the emergency room with, quote, convulsions.
Quote, convulsions. Okay, something that you see a lot on dermatology.
Yes, that's right.
So Eamonn, back to when you did your internship and back to the future, what are you thinking about when you hear that a young man comes in with convulsions?
So broad buckets, obviously the low-hanging fruit would be a real seizure. Then you could have post-syncopal convulsions, and then pseudo seizures, assuming that the term convulsions is accurate.
And let's say that it's a seizure, just so we can frame in our minds. Why would a 26-year-old have seizures? We don't know whether these are new or not.
Yeah. So that's part of the history, right? Is do they have any history of trauma, neurosurgery, any indwelling devices like a ventricular VP shunt or something like that? Is he on medications that he hasn't been taking? You have your metabolic causes, electrolyte disturbances, low or extremely high blood sugar, and then there are rarer congenital causes.
Since I don't know if you know much about me, but I'm really obsessed with acid, base, and electrolytes. Mm-hmm. So let's think about which electrolyte disorders, Dhruv. I want you to see if you can come up with all the electrolyte disorders that might cause seizures.
Oh, nuts. So I think Farron helped me start. So it's like dysnatremia. So either hypo or hyper can cause seizures. Dyscalcemia. So hyper or hypocalcemia can cause seizures. Hypomag can cause seizures and worsen the effects of hyper or hypocalcemia. Can hypo K cause seizures? I think it can. Either hypo or hyper K. And hypophos as well. And especially for someone this young, if they were, say, had some sort of altered feeding, like if they had an eating disorder, you would worry about if someone, say, had anorexia nervosa, you'd be worried about hypophosphatemia in them due to, like, say, refeeding syndrome.
Yeah, we usually think about refeeding syndrome, but I've seen people actually come into the hospital with phosphates of 0.7.
Yeah.
It does happen. So I need a fact checker. I know that hyponatremia can do it. I was not aware hypernatremia could. I was not aware that hypercalcemia could. I think hypocalcemia, what do I think of with hypocalcemia? I don't think of seizures as much as severe. So it might be confused as a seizure, but it'd be like you get more jerking and stuff like that. Hypocalcemia can definitely cause seizure.
Yeah. So
Okay.
I think
therefore probably hypomag. What about does hypernatremia cause seizure? I thought it called altered mental status, but I wasn't aware of seizures. Is anybody aware of that?
I think obtundation would be more common.
Right.
And I don't think
so. I was wondering with hypocalcemia, would you get tetany, but do you really get seizures? So FB is going to check the textbook because he's my fact checker. Okay, so those are possibles. Certainly hypoglycemia would be something we'd think about more common with the seizure than hyperglycemia, I believe. Am I overstating that, Brooks?
I don't know that I've ever attributed, I'm sure you can find a report. I don't know that I've ever attributed a seizure to hyperglycemia, but hypo, yes.
And for those people who don't know Brooks, he's one of the excellent endocrinologists at UAB, and this is his second appearance. He helped us out, I guess about a month ago, and we, for those of you who haven't listened to our discussion of aldosteronism, he was just outstanding. So hypercalcemia shouldn't cause seizures. Okay. It's always good to look these things up because we like to blame everything on everything, but I think it's the hypos, not the hypers, that are mostly to blame. I'm not sure about hypokalemia. I wouldn't be surprised, but I don't remember. Hypokalemia definitely causes paresis and quadriparesis. I just don't remember it causing seizures, and I've read a lot of severe hypokalemia cases.
Why don't we dig into a little bit more history then?
What?
Yeah.
Why don't we dive in a little bit more about the case?
Yeah, I was just having fun, Mohit. I can't control myself.
We got a lot of case to go.
Okay, so you're in charge. Take over. Why would I argue with an uprising chief resident? Never.
So the story goes, he's brought in by EMS. Family calls EMS while they're at home, because after they sat down for dinner, after eating, they were on the couch watching TV, and then soon after they noticed that he became less and less interactive on the couch, was not really responding to any commands, and then started, quote, convulsing in all four extremities. When you kind of push them, what they describe sounds more like tremors in all four extremities.
Sounds more like
no
tremors.
Bladder incontinence. He had no tongue biting. By the time EMS arrived, he was actually cleared to back to his baseline. He was talkative and didn't really recall what happened, but just kind of felt a little groggy after. But was conversant ANO ×4 after.
Okay, so in the ER, what are we going to do? What are the very first things we're going to do?
It'd probably be.
You have to discuss this.
Yeah, who do you want to?
Whoever talks fastest.
Okay. You probably want to get like a check of blood glucose. You can do.
That's always the first thing.
Yeah,
because you can do it so fast.
right.
And then we'll go ahead and get regular labs, but let's just make sure it's not hypoglycemia. You never want to miss hypoglycemia with anything neurological. I've seen strokes resolve, seizures resolve, alternate mental status resolve, and Brooks, you've probably seen more than I have. Is that what endocrine teaches us these days?
Yes, and I would, even in the hospital, same thing, because of the, we give so much insulin in the hospital, we cause a lot of this in the hospital too, not just outpatient.
Okay, so Mohit, they want a quick glucose.
Yeah. So by the time EMS arrived, it was say 10, 15 minutes after the episode, and his glucose at that point was 90. He was in his normal state of being at that point. Still with the concerning story, they brought him into the emergency room. He was still doing well on initial assessment, but then had a subsequent episode very similar to what was just described, with the addition of diaphoresis. Blood sugar in that moment was low at 40.
What? Huh. That's interesting.
So Dhruv, this is almost pediatrics.
I
this
figured,
is like a sweet spot for med peds.
Yeah, and it's interesting because this picture I would usually see present a lot earlier, like maybe around the age of like 4 or 5. So this, yeah, the fact that his blood sugar is going so low, and there are multiple things that could be causing this. It could be something genetic. It could be something that he ate. I'm remembering a weirdo little fact that if you don't process ackee, which is one of the accompaniments for ackee and saltfish, the Jamaican national dish, it can cause. It has a compound in it that if it's not processed properly, hypoglycemia can result.
Was this a Jeopardy question?
Possibly, a going to Jamaica and having ackee and saltfish. The other thing that could be considered, especially in a patient this age, would be something like an insulinoma that's been pumping out a whole bunch of insulin and his blood sugars are persistently low. But it seems a little bit too cyclic.
Okay, we have too much foreground here. We need background.
Yeah, agreed.
Right. So,
who is
this guy?
His first episode, basically.
Who is this guy? He's 26. Does he have a past medical history?
Sure. His only past medical history is anxiety treated with citalopram, 20 milligrams daily. Otherwise, no surgical history, no medical conditions. His family history is notable for a grandfather with pancreatic cancer, mother with CAD, and dad with type 2 diabetes on insulin.
What did you say the mother had, Mohit? I missed that.
Coronary artery disease.
Coronary artery disease. Okay.
So there is insulin in the house.
Right.
Yeah. And then more background on just kind of what's leading him up to this presentation. When you really push him, he says that he's been having a few pre-syncopal episodes, mainly with exertion or postprandial, that have happened maybe 5-6 times that he can recall that were significant enough to come up to his memory in the past year. And that he's gained about 30 pounds over the past year. He's chalked up some of his pre-syncopal symptoms to weight gain.
Mohit, any eating in the middle of the night or episodes in the middle of the night?
No episodes in the middle of the night, but he does say that in the middle, not in the middle of the night, but like when he wakes up for work, if he doesn't eat breakfast soon enough, he starts feeling a little woozy and then grabs some food.
So does he have a sense that eating tends to provoke symptoms or fasting tends to provoke symptoms, or is it hard for him to say?
Yeah, kind of hard for him to say. He honestly, when we talked to him, he could only describe 4 or 5 episodes that came up in his memory, but he felt that he just hasn't been well or something has been off for a while now. He just couldn't pinpoint symptoms.
So it seems to me like in my career, claims of hypoglycemia are much more frequent than true hypoglycemia. We don't get to see this very much. So Brooks, help us a little bit in, and you can get Dhruv and Eamonn to help you with this. But what is, how do you think about the differential of someone who actually has a blood sugar of 40?
Right. Well, so to your point, this term is used in kind of a wastebasket fashion a lot of times. And so we want to be precise in the way we use hypoglycemia. So there is a definition. Anybody on the call want to sort of describe what we would require to label someone as having true hypoglycemia?
I think his blood glucose is below 70 with symptoms.
You're on the right track. So symptoms consistent with hypoglycemia is 1. 70, so this is where endocrinologists, we're kind of stingy. We want 55 or less.
Okay.
The reason for that is we know young, healthy people frequently get in the upper 50s, low 60s, and that's not pathology. So we're pretty stringent on the number. And then there's one other requirement.
That corrects with
Corrects with glucose.
Yep, symptoms resolve with nutrition or glucose. Yeah, so that's Whipple's triad right there. But I think the big thing that's not recognized is we have a very strict standard of 55 typically, which this patient would clearly meet.
Mm-hmm. Where does I guess I remember, since I'm on endocrine consults now here at MCV, I remember hearing that we typically don't want to get patients with diabetes, like their glucose is below 70.
So that's a very different. So that's because your margin for error, if you're using insulin to lower sugar, once you get around 70, you don't have a lot of margin for error, and you may force those patients down with excess insulin. But people who are not on any therapy, asymptomatic patients, perfectly fine to get in the 60s, upper 50s, as long as they're asymptomatic.
So this seems to be true hypoglycemia. Now we have to figure out what the differential is so we can figure out how to do an evaluation, because he's had multiple episodes. We have a witnessed documented episode. There's nothing like a witnessed documented episode. So let's see if we can put together a list of diagnoses, and then we can discuss the different ways we might get at those diagnoses.
Yeah, and I want to interject. Somebody brought up a great point. So the 55 has to be on plasma, not on a finger stick. And it's worth mentioning the finger stick machines once they're below 70, FDA guidelines are that they only have to be within 15 points of the real number. So a finger stick that says 70 could be as low as 55. If it says 55, it could be as low as 40 and as high as 70. So we don't like finger stick machines for this kind of question.
But 40 would be good enough.
40 is real, and I assume we might in the ER have a plasma number.
Right. And by the way, that's true for continuous glucose monitoring also, because Dhruv brought that up, and continuous glucose monitors have some lags. Their numbers are not precise, but they're very useful. Mm-hmm. But the same things. Am I right, Brooks? The same. Yeah,
a place where they can be used, and that doesn't fit this patient, is if you had a patient who they themselves thought they had hypoglycemia, but it didn't seem very likely. Sometimes we use those to prove to the patient that they actually don't have it. But that would be a patient in whom you have a real low index of suspicion. That would not, this patient, you have a very high, obviously, a proof now, so you wouldn't want to use that.
And just an aside, the continuous glucose monitor is really helpful to patients who are prone to hypoglycemia, who have diabetes, because it warns them. At least the Dexcom does. And I think the
Libre is about to come out with alarms, so
Right.
it will warn them too.
And if I remember correctly, the Dexcom, I think, talks with the T-Slim pump, and you can actually like get it to I think there's some sort of control logic now that's you can have in the newer T-Slim too.
Okay, let's go back to the differential here. We know we have hypoglycemia, so let's see if we can develop a schema for hypoglycemia on the spot. Unless someone already has one you can look up. Let's think of the diagnosis. And you already named some. So what did you already name? You named exogenous insulin use.
Yeah, I would
go ahead.
I would think about it as and I'm doing this on the spot. This is not a differential I run frequently, but things that either raise a deficiency of things that raise the glucose or an excess of things that lower it. Okay. And so on the differential of things, excess things that lower it would be exogenous insulin or sulfonylureas, like you mentioned. And I have no idea about the epidemiology of insulinomas, but if that's good for this age group, possibly. And then the third thing that I can think of off the top of my head is a deficiency of things that raise glucose, which would be cortisol. So if he had some sort of adrenal insufficiency or something like that, obviously that would be accompanied probably by other symptoms.
Right. And if this kid were younger, I would maybe consider one of the glycogen storage diseases, but he's a little bit too old.
Aren't there some tumors that can cause hypoglycemia by using up glucose, Brooks?
There are, that's pretty rare. So like Dhruv, Dhruv threw out the pediatric and the adult differential are completely different. So the things like hyperinsulinemia of neonates and glycogen storage disease, though we would expect this patient to have outgrown that. So we're kind of out of the woods there. Tumors using up glucose would be a really unusual cause and not one of our big ones that we're looking for. There are case reports of that, but that's pretty rare. We have seen folks get so much tumor burden in their liver that they have no glycogen. That happens. So people with severe metastatic liver disease can get starvation hypoglycemia.
If we had the right history, I've seen patients who have wild swings between hyperglycemia and hypoglycemia. What disease do they have?
Glycemic excursion. God, now I'm racking my brain to try and figure out what this is.
Pancreatic diabetes, because as Eamonn said, they have lack of glucagon. So if they take, they don't have to take very much insulin before they become hypoglycemic, and they can't respond to hypoglycemia because their pancreas is burned out and they don't have glucagon, which is why it's so hard to control pancreatic diabetes.
Right. I don't know if this may also be a thing, but do you think cystic fibrosis might be a consideration in this patient, especially considering that it affects the pancreas? I don't know. It usually is an exocrine insufficiency, but there are cases of like diabetes and cystic fibrosis. And I would imagine that diabetes would tend to be a little bit more brittle because you're actually destroying the entirety of the pancreas.
Can you help us there, Brooks?
Yeah, we don't see much hypoglycemia in CF, but CF definitely causes diabetes of its own. It's an insulin deficient type of diabetes. But I don't think they may be prone to hypoglycemia when they're treated because of their lack of pancreatic function, but not prior to treatment.
Okay. What have we left out of the differential, Brooks?
So the way I would frame this is sort of drugs. That would be my top three. Just because drugs either intentionally or unintentionally. Insulinoma would be, you guys have talked about that. And then the big category, so there's some IGF I saw in the chat, which I agree with. These are rare, but tumors that secrete products that bind the insulin receptor, such as IGF-1, big IGF-1. There's some unusual molecules that a variety of tumors can make that hit the insulin receptor. So they don't actually use up glucose, but they hit the receptor. And then the big class of autoimmune hypoglycemia, which is kind of fascinating. So people who get anti-insulin antibodies and anti-insulin receptor antibodies, both of those types of folks can get severe hypoglycemia.
Okay, so now we have to figure out what to do with this unfortunate young man. So Eamonn, write your orders.
So for treatment, I think if with this kid's history of recurrent episodes and blood sugar that was down, and then I'm sort of envisioning it as his body responded to the hypoglycemia with a surge of, catecholamines, glucagon or whatever, and it came up, but there's this sort of persistent downward force, and he may be prone to that again. So I don't know if you would put him on a like a dextrose drip or something like that to prevent the hypoglycemia while you were working up things. But that would sort of be a buffer against severe hypoglycemia. And then you would, since that seems to be his main problem at that point, initiate a workup for what's on your differential. So further history, make sure that he's not, taking the insulin, things like C-peptide I know is in there. I'm not sure about whether with those tumors, if you measure IGF levels directly, and then maybe look at a cortisol and assess the function of his pituitary gland.
Okay, so let's actually try to be very specific about the test, because this is unRemarkable labs. So we need to figure out what are the right lab tests to get. Dhruv, Eamonn gave us a bunch of stuff. What do you want to order out of what Eamonn said?
So I'd probably get an insulin level, a C-peptide level, an IGF-1 level. The one thing that I'm trying to think of is whether or not we would need to get any of these tests post something that can provoke the hypoglycemia, something like, and this was mentioned in the chat, either a mixed meal test, or what we do at MCV is a prolonged 72-hour fast, where we essentially check at specified time points serum glucoses, and once the hypoglycemia hits, then you send the whole panel of the hypoglycemia labs.
Do you so this is a question for Brooks. I know you can check for whether there's sulfonylureas in someone who's not taking, not supposed to be taking sulfonylureas. And there are tests for that?
Yeah, so there's a sulfonylurea screen that will also check for the glutenides that are kind of cousins to sulfonylureas. And I would send that immediately because that takes days to come back. And we'll see as this case evolves, but I always want to get that sent right away because a lot of times we're sitting around waiting on that one. Because as we interpret the labs that we're probably going to talk about, it's hard to do without that sulfonylurea panel back.
Is it worthwhile to check cortisol? They mentioned cortisol, and I think Addison's can give you
yeah. So
hypoglycemia.
We always rule out adrenal insufficiency, just sort of poor form to do $1 million workup for insulinoma and then find out it was adrenal insufficiency. So that should be ruled out quickly with a court stem, get that over with, get your answer there.
Yeah.
So this is an interesting question because this comes up all the time. It's the middle of the night. Dhruv is on night float. This guy gets admitted. Is there value to getting right during the stress period a random cortisol as a clue? And I've been told that if the cortisol level is above 18, we don't even have to do the court stem.
That's right, and probably over 15. So the data shows the gold standard is any value of 18 or higher on a court stem or randomly. But if you get one 15 or higher, the odds of passing the court stem are in the upper 90s. So I'd be happy with a random cortisol 15 as a rule out.
What might be some classic questions, since Addison's is in our differential, what would be some of the classic questions that you might ask someone to screen for Addison's? Just by history, what is different about people who have Addison's?
I think they will, a very large majority of them will have orthostatic hypotension.
Okay.
And then you can also ask about fevers, abdominal pain. And depending on whether it's primary or secondary, you can also see unique findings like hyperpigmentation that develops in like the palms and the oral mucosa and the areola.
There's a particular dietary thing, and I saw a young woman about this age with Addison's when I was an intern, and there was something striking when I walked in the room.
I think Kushal mentioned it, like craving of salt.
Yeah, she was eating potato chips constantly. So salt craving that's an interesting question to ask, of whether or not they have been self-medicating with salt recently.
Or do you eat sushi because of the high sodium load that the soy sauce can give?
So can you give us, just because it might be interesting, why don't you give us the rest of the electrolyte panel if you have it, Mohit?
Yeah, absolutely. So electrolyte panel, sodium was 140, potassium 3.6. Making sure that I don't speak too fast. Chloride 106, bicarb 26, BUN 10, creatinine 1, calcium was 9.
See, you sometimes see hyponatremia with Addison's, but you don't always see it. So that doesn't rule it out. If it had been hyponatremia, we'd have said, we're going to think about that more.
So Mohit told us the patient had gained weight. I'm going to tell you that rules out Addison's. There's one series of people with primary adrenal insufficiency, looking at their symptoms, 100% had weight loss.
Mm-hmm.
So gaining weight and Addison's don't go together.
Is that primarily from like fluid, or are they losing fat, or do we?
Fat, yeah, they're basically just catabolism. They're unable to maintain. They have poor appetite, chronic nausea, vomiting. So weight loss is almost universally seen.
So Mohit, can we get some of those labs that we listed in the workup?
Yeah, absolutely. I do have a CBC, but it's not really necessary for this discussion. So
if Addison's was still in the differential, finding eosinophilia might be a clue, but it might be a clue.
It wasn't there. TSH was within normal limits. Random cortisol was drawn in the emergency room, and that was 20.
That's normal.
Other labs kind of that we talked about, the C-peptide level was ordered, and that was elevated at 4.
How does that help you, Dhruv?
While in the emergency room, I will tell you, he had a CT abdomen pelvis, which showed no abnormalities in the abdomen or pelvis.
Okay, never mind. That doesn't help.
Dhruv, you're on endocrine. How does the C-peptide help us?
So if the C-peptide were like low normal and we were thinking about insulin, we'd maybe have a piece of data that would suggest that it would be exogenous insulin administration, since that insulin does not have C-peptide attached. Right. Whereas insulin that's secreted from the pancreas is basically proinsulin, which has insulin and C-peptide. The C-peptide gets cleaved, and then if you're essentially pushing the pancreas or some other source is pushing insulin out, you'll get elevated C-peptide.
So this is making us think that there's too much insulin.
Mm-hmm.
And too much endogenous
insulin.
Is our reasoning correct, Brooks?
Yes, although the big caveat here is these are completely uninterpretable without a glucose. So until Mohit tells us the glucose, these labs are not helpful because, if they gave him an amp of D50 an hour ago, I would expect the C-peptide to be elevated.
So what's your timing, Mohit?
Yeah, so this was actually all drawn on evaluation in the emergency room by the medicine team, where he in the emergency room had another episode where he was getting diaphoretic, tremulous, kind of altered in the moment, and then had another glucose drawn that was low again. I forget the exact number, but it was definitely less than 50.
Good.
So now we're in a search for where's he making insulin?
So the one thing I would say though is, the labs, a C-peptide would be elevated. So Drew, your point of if he was taking insulin, he should have a high insulin, low C-peptide. That's correct. But if he was taking sulfonylurea, C-peptide would be high.
Right.
And the sulfonylurea, a few days fast forward, is negative. That panel is negative. And then the another thing that was brought up in the chat, I think the insulin-like growth factor level, that was also not positive. I forget the reference range for his age group, but it wasn't elevated.
Okay, so now we're going to, the story's consistent, even though the epidemiology is a little young for an insulinoma. It sounds like it's an insulinoma. Do any other tumors produce insulin other than, I mean, could it be extra pancreatic, or is it almost always pancreatic?
Usually pancreatic, but they can be, GI neuroendocrine tumors as a class can be in a variety of spots. So pancreas is going to be far and away the most likely, but there are reports of ectopic neuroendocrine tumors making insulin.
Okay, so why don't you teach us what you would do now, Brooks, because this is definitely, I'm calling endocrine. I called them a little while ago, but I don't need to remember this, but I want to learn it. I'll forget it again because unless I see somebody with hypoglycemia within the next year, because if you don't see it, you don't remember it.
So the first thing I'd say is you got lucky. So catching these labs in hypoglycemia can be really challenging. So if any of you done a 72-hour fast, it's really hard to get it done right. The biggest problem we tend to run into is it gets stopped too early. So folks, nurses who are taking care of the patient get nervous when the sugar starts getting low. They pull the trigger too early and they feed the patient, and then we don't have the labs at the right time. So we've gotten really lucky in catching the labs during an episode of hypoglycemia. We don't have the insulin back yet. So if our hypothesis is that this is an insulinoma, the insulin should be elevated, and so should proinsulin. So I'll kind of walk you through the labs that we get. So why do we get beta-hydroxybutyrate? Let's say that one first. So what does beta-hydroxybutyrate tell you if you check it when somebody's hypoglycemic?
I'll just give an answer, and if I'm wrong, you guys can correct me. So I think of that as a ketone that normally appears when there's a deficiency of insulin. And so if they have that present, then that would mean that there's not an insulin deficiency, So I don't know if that's correct or not.
So if it's present, they are insulin deficient, right?
Oh, that's what I mean. Sorry.
Yep. So that's correct. So it's useful. Basically, if you see beta-hydroxybutyrate, the body's trying to feed the brain with something. Right? Basically, your body's telling you, I don't have insulin. I don't have a way to get glucose into the blood-brain barrier and keep myself from dying. So beta-hydroxybutyrate is my response to give the brain some fuel. So that suggests no insulin. And so you'd see beta-hydroxybutyrate in DKA, but that's with a high sugar. So the scenario here where you typically would see beta-hydroxybutyrate is starvation. So patient who's just severely malnourished, patient, that example I gave you, the bad metastases to the liver and a lack of glycogen, you'd see beta-hydroxybutyrate there. So if it's low, you know it's an insulin or insulin-like molecule mediating the process, and it's shoving sugar into cell. I mean, it's shoving, so insulin is shoving sugar into the liver, you're making plenty of glycogen, and insulin's present and causing the sugar to go into the cell, but not into the plasma. So your sugar in the plasma is dropping, but the cells are happy because there's insulin around. So your brain is not perceiving hypoglycemia. So that's where that's useful, is mainly discerning starvation. So you guys.
Do we have those tests, Mohit?
Say again.
I have an insulin level, which was elevated at 50. I think the reference range cutoff was 25. And then I didn't jot down the beta hydroxybutyrate level. I'm blanking on what it was.
And did you have a proinsulin?
No, we didn't get one.
Okay.
That's fine. And so the proinsulin and C-peptide kind of tell you the same thing. So if the patient's making their own insulin, they'll have C-peptide and they'll have proinsulin, which is an insulin precursor molecule. So they're very similar. They're basically telling you the insulin's coming from biologically within the patient. And so as you guys already alluded to, if you had a high insulin but low C-peptide and low proinsulin, that's suggestive of exogenous insulin. So that's why we draw those. The only thing missing on this list would be insulin antibodies or insulin receptor antibodies. And they could cause a picture like this because the way insulin antibodies work is they bind to your endogenous insulin, carry it, keep it from being used at the receptor. And then when the antibodies come off of that insulin, you've got free floating insulin that's not secreted along with your meals. And so it hits the receptor in an unregulated way. So that's still theoretically possible here, but probably not very likely.
So how are we going to find where the insulinoma is?
Yeah, insulin antibodies were negative, by the way.
Okay.
They took them back.
You do that scan, the octreotide scan.
You like
I
that,
would
Bruce?
wait on that. Anybody got another suggestion?
They did a CT of the abdomen.
Yep, reasonable place to start, although you want to be sure it was done by pancreatic protocol, where there's a pre and post contrast image and you're looking carefully in the pancreas for contrast uptake in these small tumors. So need to be sure that that was done, a good CT scan. But a lot of institutions prefer another test. Anybody? Do I know what that might be? EUS, so you're on the right track. So endoscopic ultrasound. A lot of institutions actually start with that. And that you go down into the esophagus and take advantage of the fact that anatomically the pancreas is right there and can find really small tumors there. And then MRI can be used as well. It's similar in terms of sensitivity to the CT. And so a lot of it depends on the expertise at your institution. But in this case, if we had a normal CT, I'd probably suggest an EUS.
That's exactly what happened. He got an EUS with our advanced endoscopy team, which showed a very small, it was less than 1 centimeter by 1 centimeter pancreatic head mass that was biopsied with the final diagnosis. But I can leave that, or I can give you the diagnosis, which I think everyone is kind of now.
Yeah, hit us with the punchline.
Yeah, so you end up having insulinoma as a diagnosis. Went for an operation to resect that with surgery. With that operation, had no recurrence of symptoms in the hospital. Was discharged safely. Still pending follow-up to see if he's having recurrence of symptoms, but I guess the likelihood, since that was a diagnosis, would be quite low.
Mm-hmm.
So did he, if you're going to have an insulinoma, you'd rather have it at the tail than the head because the operation's a lot easier. So did he have a Whipple?
He Did he have a Whipple? I'd have to look back at the op report. I was gone by the time this happened. This is actually a case that was inspired by one of our morning reports. So I got a lot of the information from one of my colleagues.
Okay, so well, let's go with let's figure out what the big take-home points are. And I'm so impressed that Eamonn joined us in his third year of dermatology, far removed from internal medicine. And it's amazing how much stuff you remembered. I was really impressed, Eamonn.
Oh, thank you.
You did
Thanks
great.
for letting me join. This was a lot of fun.
So what are the, give me one or two things that you really want to take from the discussion of this case. I like to do this at the end of most discussions. I do this on rounds all the time. It's really, really helpful for you to repeat what you think you learned because you're more likely to remember it. Plus, it's going to give Brooks and I a lot of information on all the things we discussed that seem most important to learners.
So for me, at least, the two things that stick out to me are one, the importance of time course. In this kid, this sort of gradual and repeated episodes are striking and sort of help pull you away from the diagnosis of exogenous substances, because that would be less likely. And then for me personally, because I'm not as practiced with the workup of this, was the, your typical battery of labs, and how you can use things to quickly cut down your differential, like the betahydroxybutyrate, to say whether it's a lack of intake versus an overproduction.
Dhruv?
Yeah, this was, so I was very familiar with, the sort of the pediatric version of this hypoglycemia workup, but it's interesting to see sort of the different diagnoses that we would be thinking about in adults, particularly insulinoma. And honestly, this patient is sort of in the middle of the two, where you could sort of honestly maybe see a couple of those diagnoses overlap. But this kid, yeah, and Eamonn, I think, got a similar idea to me in referring to this patient as a kid.
Well, that's because he's younger than Eamonn.
Well,
Makes him a kid.
Although to be quite frank, insulinomas in this age group are very rare, and it makes me wonder whether or not this patient has like a genetic neuroendocrine tumor syndrome or something like that.
Mohit, you chose to present this case. What did you get out of this discussion?
Yeah, I think one of the big things that I took away from it is don't discount hypoglycemia causing a vague presentation regardless of time course. So I think in the initial morning report when we had it, hypoglycemia wasn't necessarily on my differential, except for the fact that he had, quote, convulsions or possible seizure at home. But just anyone who has kind of pre-syncopal symptoms, lightheadedness, wooziness, you should always check glucose. It's a very quick and easy thing to do, and it's like we were talking about, would be very poor form if you missed it. The other thing that I took away from this, and part of the reason why I wanted to present it after I heard this case, was the workup. This is not a very common workup for insulinoma. We talked a lot about the timing of getting these tests, that they should be taken from the patient when the glucose is actually low, and prior to like an AMP of D50, because that can really botch the tests. And then, we quickly went through the imaging, but I think that was another really noteworthy finding for me, is that just because you have a CT or an ultrasound that is negative, they're not the most sensitive tests for an insulinoma. I think I saw 70% sensitivity with CTs. So even if you have a negative CT, you should still really search for it if the suspicion is high enough. We talked about MEN1. He did ultimately get tested for that. Does not have MEN1 syndrome, so that's good for him.
Brooks, what do you want us non-endocrinologists to have learned from this case?
Just how to define hypoglycemia. I think the term gets used a lot more than we actually see it. And I think it's helpful to be kind of rigorous about that definition.
Great. And Sean, you're the genius behind all the pearls and differential thoughts. What did you get out of this?
Oh man. So I always forget that the definition is a glucose less than 55. And I feel like I've been burned so many times where somebody has like a 60 and then we treat it, but it's really to emphasize that you wait till they go real low and then you check these labs. And then I did not know that the CT abdomen pelvis, that sensitivity is terrible, a 70%. And I didn't know about the next step being in EUS. So that was a learning point for me too.
And I will second the EUS. I like both the things that you mentioned, Sean. I think being rigorous about the definition was really useful. Knowing what all the tests are is very useful, and knowing that EUS is very sensitive for picking up the insulinoma, because we're fortunate at UAB to have very good EUS, and so that's what we would go to. And it sounds like WashU is the same, and you had that opportunity. I'd like to remind everybody, next week is going to be early. We're going to start at 6 Central Time, 7 Eastern Time. Let's see, 5 Rocky Mountain Time, and 4 West Coast Time. I have no idea about Hawaii. I don't know what time it is in Brazil right now. I don't know what it is in India right now. We have an incredible case to discuss next week. And all I'll tell you is that Jory May is going to be here and the patient has back pain. Comes in with 10 out of 10 back pain. And I promise you that you will find it extraordinarily interesting in many, many ways. What is 10 quotes versus 10 question mark?
Actually, a 10 out of 10.
Yeah, actually a 10 out of 10 versus.
No, it actually is a 10 out of. No, this guy is not smiling. This was actually my patient. So I know all the details of this case. There's so many interesting things to discuss, so many interesting labs to discuss, that I think you'll find it very different than everything we've done up to this point.
Woof.